Hello, friends. Today I have come with a very small topic. However, this topic is very important, very common, and very intriguing to the patients, especially because they have lot of small problems in this, but they get worried. Even many obstetricians do not know how to tackle this problem, and there's always confusion with serious issues with liver disease. And this can be definitely a theory question in the exams because such small, simple cases may not be kept in the exam for practicals or case discussion. So let's jump into straight away the small topic of intrahepatic cholestasis. In fact, uh, why I prepared this topic is long back one I received one email from an unknown person somewhere from Madhya Pradesh, and of course, he was praising me a lot that he said he searched for me in the Google and then he thought I'm the best person to contact. And all that his wife had was intrahepatic cholestasis, and then pregnancy had a very good outcome. There was no problem at all. And he is still in touch with me even today. So I thought this is very intriguing problem for all the patients. So I thought I should take this. What are the synonyms or synonymous terms for intrahepatic cholestasis, or what are the characteristics? Recurrent jaundice of pregnancy. Now we know there are several causes for jaundice, starting from infections to the serological problems, transmission to through sexual intercourse or injections, or it could be a simple cholestasis of pregnancy. But whatever it is, it really definitely bothers the patient. Recurrent jaundice of pregnancy is a synonymous term. Cholestatic hepatosis is another term, and icterus gravidarum. Of course, icterus gravidarum is very obvious. Icterus means jaundice. Gravidarum is during pregnancy. What are the characteristics of this? Pruritus is the leading symptom, and this is so bad that the patient really gets irritated with this pruritus. No ointment, no nothing, oil helps these patients, and they will be initially visiting the dermatologist, but then they will realize the problem is not outside, the problem is inside and deep inside the liver. Icterus. Okay, this should give a clue that the problem is not a skin problem, but it is a deeper problem. So icterus will definitely give away the diagnosis, especially during pregnancy, and for a known obstetrician or a smart obstetrician that it is cholestasis of pregnancy. Or there could be both. So the patient who comes with both, the diagnosis is easier. What are the risk factors? More common in multiple pregnancy. So obviously it is something to do with the hormones of pregnancy or the changes, physiological changes that take place in the liver and all the other systems in pregnancy. Multiple pregnancy means more problem, isn't it? More prominent physiological changes. So that's exactly why it is a risk factor. Genetics. Not all pregnant women will have this because otherwise, this should have been much more common and everybody should be knowing. It happens in only few pregnant women. That's why there is a genetic background. The incidence varies uh, between the populations. In some populations, it is more. Numerous mutations in many genes that control hepatocellular transport system. For example, mutations of ABCB4, which encodes multidrug resistance protein 3, associated with progressive familial intrahepatic cholestasis. So if this happens, even if it was not hereditary, then there could be problem in the patient. Other one is ABCB11, involved in a bile salt export pump. Of course, these things have to be remembered hard way for the exam's sake. After that, you will only know A, B, C, D, E, F, G, H, I, J. Drugs, of course, azathioprine after renal transplant. If somebody has been receiving this for suppression, immunosuppression, then there will be cholestasis. Chronic hepatitis C, we all know about hepatitis A, B, C, and all those things. Somebody has got chronic hepatitis C. That's why we have nowadays started, whenever there's jaundice, sending for all of them, hepatitis A, B, and C. Somebody having chronic hepatitis C will have cholestasis of pregnancy. It is as high as 20-fold. What is the pathophysiology? Bile acids are usually cleared incompletely and accumulate in the plasma. So these are the ones who sit under your skin and start irritating you, and you will feel the itch. It is the bile acids. So that's very, very important. Bilirubin is elevated due to retention of conjugated pigment, but total plasma concentrations rarely exceed 4 to 5 milligrams per dl. So this is the main differentiating point between cholestasis of simple cholestasis of pregnancy and hepatitis. In hepatitis, the bilirubin is elevated very much, as well as the other liver enzymes also. So bilirubin here is not very high, rarely exceeds 4 to 5 milligrams per dl. Alkaline phosphatase is usually elevated. Serum aminotransferases are normal to moderately elevated, but seldom exceed 250 international units per liter. This is what I was trying to tell you. The main way of differentiating simple cholestasis of pregnancy and other serious problems like hepatitis A, B, and C is that the serum aminotransferases are normal. I'll repeat, serum aminotransferases, ALT, AST, what we say, are normal. They can be moderately elevated, but seldom exceed 250 international units per liter. Same also in fulminant hepatitis, the enzymes are very much elevated. So once the enzymes are within normal limit, you can be rest assured that it is not a very serious problem. Yes, of course, it's a irritating problem. The patient has pruritus all the time and she will get worried. That's enough for her to get worried. What's the pathology? There's mild cholestasis. As the name suggests, cholestasis, there's stasis of all the, uh, with the bile plugs in the hepatocytes and canaliculae of the centrilobular region, but without inflammation or necrosis. This is how it differentiates between the infective hepatitis and other hepatitis. There is no inflammation or there is no necrosis. Changes disappear after delivery. So I other day was telling that any problem that is due to pregnancy, the three general points. I'll repeat again because let me repeat it every time so that it is nicely ingrained in you. Any problem which is due to pregnancy, exclusively because of pregnancy, will show up after 20 weeks, half of pregnancy. Number two is that they keep deteriorating as the pregnancy advances. And number three is they will all disappear after delivery. So delivery is the definitive answer for them. The question is when to deliver. So you cannot deliver too early because of maternal issues. You cannot deliver too late. Then there will be effect for the fetus also and mother, but often recur in subsequent pregnancies or with estrogen containing contraceptives. So it is something to do with the pregnancy hormones. So of course, the estrogen only comes up little later in pregnancy towards the end, but throughout the pregnancy it is the progesterone, that's the hormone. So there is a recurrence for uh, intrahepatic cholestasis in subsequent pregnancies. This is a very, very, very important slide. I'll take some time on explaining this slide. You can take a screenshot of this, not only through your cameras, but also in your minds forever. You are going to be obstetricians, and this is required throughout your life. So look here. There can be jaundice because of any reason, as I told you, as simple as hyperemesis gravidarum can give rise to jaundice. But how do you differentiate that? Onset is early in pregnancy. Usually hyperemesis gravidarum is early in pregnancy, isn't it? I told you cholestasis of pregnancy should be in the second half of pregnancy or later in pregnancy. But here the problem, which is pregnancy related, but this is the only problem which comes up contrary to my general formula, that is 20 weeks, after 20 weeks. Hyperemesis is the one problem which is exclusively due to pregnancy that can appear in the first trimester before 20 weeks, because this is a sudden change in the environment. There is a lot of changes, but the main change is the increase in beta HCG. So that happens in the early pregnancy. Later, it stabilizes after 100 days. So hyperemesis is the problem which can give rise to jaundice and cholestasis and problems. So clinical findings are severe uh, issues, and it can be asymptomatic as well as. Hepatic enzymes, as you can see, normal or 300. It's not very high. Bilirubin again is normal or up to 4. Renal parameters are increased. That generally happens in hyperemesis due to hypotension as well as hemoconcentration. Patient has been vomiting and losing fluid and electrolytes. Um, Hematological and coagulation factors. Hematocrit is elevated because of hemoconcentration, hypovolemia. Platelets are normal, fibrinogen is normal. Other degradation products are normal. Platelets again are PT is normal, hemolysis is not there, right? So this is hyperemesis. The main striking point is it happens very early in pregnancy. The rest of it is almost normal, except the effects of hemoconcentration. Now I come to cholestasis of pregnancy, which is the topic of the day. As you can see in the first column, onset is late. So this is the problem which takes some time for the cholestasis. Clinical findings, pruritus and jaundice, which I have already told you. It can be singular or plural. Both of them can be there in a patient. Again, look at the AST, ALT. I told you already, they are normal, less than 250. So in hyperemesis, in fact, it goes beyond 250, but here it is normal or 200. That is the hallmark. Bilirubin, again, I told you in the very first slide, it is not very high. It is up to 5 only. Renal functions are normal. This is how you can differentiate. One is late onset compared to hyperemesis, which is early onset. The second differentiating point is that renal parameters are normal in cholestasis of pregnancy, whereas in hyperemesis, they're elevated mainly because of hemoconcentration and hypotension, and there's lack of blood supply to the kidneys. Hematocrit is normal again. Again, this is the another differentiating point between hyperemesis and cholestasis. If you just see above, it is a double arrow up. You know, it is highly elevated hematocrit because of hemoconcentration. Again and again, I'm saying the same thing. Rest all is of course the same normal and no hemolysis here also. So late is the underlining point. And of course, liver enzymes are within 250. Bilirubin is low, not very high at least, and platelets are normal here. Why I am now circling platelets? In fact, I was talking mainly about the elevated renal parameters as well as hematocrit, but I didn't circle them. I have circled this because the platelets will be low in case of, the HELP syndrome. That is the differentiating point, which is going to come up little later. Fatty liver of pregnancy, this is a very, very dangerous issue. There can be fulminant hepatitis, fatty liver, and that requires immediate delivery. Otherwise, there can be danger to the fetus as well as to the mother. Of course, it is also a late onset in pregnancy. The clinical findings are moderate. There could be hypertension or there could be liver failure also. And you can see the AST here, it is very high, 200 to 800. Jaundice also higher compared to cholestasis of pregnancy. Renal parameters are bad, they are elevated. Hematocrit is elevated. Platelets have decreased. This is somewhat like happens in HELP syndrome. And fibrinogen is decreased, and degradation products are increased. Prothrombin is increased, and there is hemolysis. Okay, so this is how you take it. It's late in pregnancy, and I have made it a amber color. It is like traffic lights, green, amber, and red. So red is going to come up. Don't worry. So and of course platelets are decreased is the main differentiating point I was trying to tell you between cholestasis and fatty liver of pregnancy. Now comes preeclampsia, which is HELP syndrome. It is again mid to late. Preeclampsia is manifested after 20 weeks and it keeps on worsening. So it is mid to late. And of course, there is hypertension. This is the main feature that you can differentiate between simple cholestasis of pregnancy, fatty liver, and even hyperemesis. In hyperemesis, in fact, there is hypertension. Of course, hyperemesis does not last that long, up to mid and late trimester. And you see, the enzymes are elevated, but not to the extent of fatty liver. Bilirubin, again, of course, is up to 4, but renal parameters are increased. Hematocrit is increased. That is a normal feature of preeclampsia. Platelets are decreased. Again, HELP syndrome. What is HELP syndrome? I've been telling HELP, HELP, HELP. So HELP is, hemolysis that is increased here, as you can see, double arrow, and hemolysis, elevated liver enzymes, of course, and low platelets. That is HELP syndrome, right? So I'm encircling hypertension here to highlight that. Late is anyway common for all of them, but hypertension is the differentiating point. And of course, amber colored elevated liver enzymes. In fact, less than amber color. I put it as yellow color actually. And platelets are decreased, red circle. Now comes the hepatitis, the infective one. That is variable in onset because hepatitis can be contracted anytime, early pregnancy, mid pregnancy, late pregnancy. So there is no specific. Jaundice, jaundice, jaundice. Jaundice is the main feature. And look at that AST, ALT, 2000 plus. So even a blind person can diagnose hepatitis A. Just looking at the deep jaundice, 5 to 20, 5 to 20 bilirubin. Liver enzymes 2000 plus. That's it. You don't even have to prove serologically or by any other means. The biochemical testing alone can tell you that it is hepatitis A. So that's why I was trying to tell you, now you can understand why I was harping that this is the most important slide. This slide you should keep in your mind all the time, not in your mobile, not on the wall, not on the books, but in your mind. This is very, 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 very important. Look at that renal functions. They are normal. Hematocrit may be there because the patient may not be taking enough fluids. That is increased. Platelets, yes, of course, it is decreased, but not so to the extent. No double arrow there. No, I have not encircled anything. Fibrinogen and degradation products and D-dimers and all are normal. And PT is slightly elevated. There's no hemolysis at all. So this is the important table that will differentiate between infective hepatitis, where there is deep jaundice, and in very, very highly increased AST/ALT. Preeclampsia, of course, hypertension is the differentiating point. Of course, liver enzymes are elevated mildly, platelets are low. Fatty liver, again, the enzymes are elevated, jaundice is there, but it's not to the extent of hepatitis. Platelets are decreased, cholestasis, you see, all green. Very mild elevation of the AST/ALT, bilirubin also mild elevation. Platelets are normal, late onset, not as deep jaundice, just an irritation, pruritus. So let me move now. What are the symptoms? I have already told you about that, pruritus and of course jaundice. It precedes lab findings. Initially people will think that maybe it's because of winter or skin condition I'm having itching, or maybe I ate something which is allergic, that's why I'm having itching, or maybe some makeup that is not suiting me, that's why I'm itching. People will always think of positive things. In fact, we say people are negative, they are not. They always think of positive things. They'll always think of a serious problem in the end, unless it becomes intolerable after applying the oils, after applying Vaseline, after applying so many other things, taking some antihistamines on their own, then they realize that it is a deeper problem. Late in pregnancy, of course, this is what I have already highlighted in the previous slide, generalized with more in souls. So the itching is not restricted to the allergic areas like, the makeup areas or other areas. It is generalized. Everywhere there is itching. Whereas the itching due to winter or due to burning heat or sweating is only to the exposed areas. And itching due to makeup, side effects, and all that is only on the facial areas, whereas it is generalized here and it is more in the soles. Skin changes, of course, when you keep itching, there will be excoriations from the scratching. Some people will have some wounds also. There will be bleeding. They scratch so much, especially if your nails are very long. No constitutional symptoms. There is no fever, no nothing. That is the difference between simple cholestasis of pregnancy and other serious issues. Jaundice, of course, is there. As I told you, mild jaundice up to 5 milligram, but it is only in 10% of the cases. Pruritus is the leading point. If both of them are there, it's easy. But I said only when pruritus is there, the last thing you think of is cholestasis of pregnancy. Now onwards, you should think first thing as cholestasis of pregnancy. What are the effects on mother? Is it just that irritation and itching? But there are effects. It is associated with preeclampsia and GDM also. Because see, these ladies generally have some genetic problems. Preeclampsia is also genetic problem. GDM is also genetic problem. So they are all cousins, I can say. Dyslipidemia is the underlying point, which will give rise to preeclampsia, GDM, and generally cholestasis happens in both of them. Even just like that, in obese patients, these things can happen. Significant increase in labor inductions and cesarean deliveries. Uh, Caesarean can be spelled CAE or CE, both can be there. So I've just left it like that. Anyway, coming back to why there's induction in labor and cesarean deliveries, because generally when the liver enzymes are elevated, people get scared and then they don't want to give, wait till the normal delivery that happens. And because the patient's problems are also increasing, they want to induce labor. And when they induce labor, suppose you are inducing too early, not at the right time, then you give up within 4 to 6 hours. Nowadays, nobody has patience. Neither the patient has patience, nor the doctors have patience. So you give a short induction of 4 to 5 hours, and then you declare it as failed induction and take up for cesarean section. In fact, patients are begging for cesarean section. They can't even tolerate pains for 4 to 5 hours. So that's how the cesarean deliveries are increasing. What is the effect on the fetus? Of course, PR interval on fetal echo was significantly prolonged because of bile salts and bile pigments. This is the effect of that. And bile acids may cause even fetal cardiac arrest, not just prolonged PR interval, they can cause cardiac arrest. So that is the reason we should be worried. Mother, of course, she can manage the itching and irritation. She can apply some ointment. She can take some antihistamines or she can take antibile acids. But the baby can have cardiac arrest. In fact, there was a large study. A good friend of mine from King's College was doing this study on bile acids, effect of bile acids on the fetus, and they found that cardiac arrest is very, very high. Sudden fetal death despite normal NST. This is very intriguing. We always say the NST has got a 100% negative predictive value. That means if NST is normal, there can't be any problem for the fetus. But this is one area that is cholestasis of pregnancy can have sudden fetal death. So, in fact, when there is a sudden fetal death, it is wiser to estimate the bile acids for some explanation. Of course, patient will not excuse you. They will get the explanation, but they will not excuse you. They will say, why you didn't do this earlier? So don't neglect any itching, especially in pregnant women. This can be very dangerous to the fetus. Don't you agree with me now? It's a short and small topic, but so much of importance is there in this topic. Increased neonatal complications. Of course, when there is increased prolonged PR interval and there are other problems with the heart, there will be increased neonatal complications. Perinatal mortality is slightly increased, of course. Perinatal mortality is nothing but any death after 28 weeks up to 7 days is increased, but death limited to severe disease. So wherever bile acids are more than 40 micromole per liter, then only death occurs. Mild elevations will not really bother. So it's important to estimate along with the liver enzymes in this patient bile acids that has to be estimated. If it is more than 40, it is dangerous. What is the treatment? Antihistamines, of course, whenever there's itching, that's the first thing that comes to anybody's mind. But antihistaminics can make you drowsy, so we have to choose the later ones or latest ones, which have got less, depressing or less sedation. and usually it is given in the night. Cholestyramine, 8 grams per day effective, but causes further decrease in absorption of fat-soluble vitamins, which may lead to vitamin K deficiency. So you have to give that to the baby when it is born, which we are giving as a routine, but we have to keep that in mind. Fetal coagulopathy may develop, and there are reports of intracranial hemorrhage and stillbirth when you give these drugs because of vitamin K deficiency. Topical emoluments, this is the second line of treatment which all the ladies would, before going to the doctors, they themselves use it. But the mainstay of treatment for cholestasis of pregnancy is that urodeoxycholic acid. The trade name usually we all remember Udiliv. I usually don't take trade names, but that's the one which is more popular than urodeoxycholic acid. So 8 to 10 milligrams per kg per day. It relieves pruritus, no doubt. It lowers bile acid. That is very, very important. Anything more than 40, I told you, milligram is microgram rather, is very, very dangerous to the fetus. It can cause cardiac arrest. So any drug that you give should lower the bile acid. The earlier ones, the antihistamines and the emollients, they will not decrease the bile acid, but ursodeoxycholic acid, I think now I pronounced it correctly, lowers the bile acid and serum enzyme levels as well. It may reduce certain neonatal complications such as preterm birth and fetal distress, cardiac arrest, respiratory distress, and an ICU admission. So that's very, very important. So there I am. I finished the topic. I think I took the shortest time, but it's a very, very important topic, as I told you, because this cholestasis of jaundice is not very serious to the mother. It's just an irritating problem to her, but it can cause serious effect on the fetus, especially when the bile acids are more than 40, and then that can cause cardiac arrest. So you have to give some antihistamines and the lotions, but along with that, also deoxycholic acid also should be given to relieve the pain. I'll come up with another topic tomorrow. Till that time, you enjoy. I hope you are all listening to the topics. I don't see a lot of views because maybe you are busy with your own way of studies, and but when you are sleeping almost, or if you are not getting sleep, listen to these topics. Or when you go for walking, relaxing, or lunch, just put it like a podcast in your ears and listen to them. They will be useful, I'm sure.